I think that there is a big problem with determining a metric is not valid because of lack of data. Now, it's fine if the lack of data is equated to lack of subjects. In other words, the study wasn't big enough. But we've had at least one metric in the past year. This had to do with long-term care visit plans where facilities weren't performing the task. And again, it was determined not valid, but yet this is a common sense metric that you need to have a long-term care plan that's good for patients, and yet that wasn't performed. And we had also a number of metrics, and I would include in this the metric on renal wait listing, and I also think the metric on wait times in the ER, where there wasn't good double-blind studies that show that this will affect quality. Well, on anything that is a current standard of care, that's very important to be measuring and monitoring, it's extremely difficult to get double-blind studies. How can you have a patient control group? And so in these cases, and these are the most important metrics, we can't hold them up. We cannot defeat them because they're not valid or we don't have validity data. Similarly, you can't do a study that will show that postnatal visits are important. How can you have a control group that doesn't get the visits and an intervention group that does get the visits? It's not ethical. You can't get the data. So again, a metric to measure that based upon validity could be defeated because we don't have a good controlled study. So there are many times, especially involving standards of care, metrics that record standards of care, that we are not going to have the type of hard data that you can have with other metrics. And so I really think that based upon a lot of the past experiences and our previous decisions, that there's a lot of variation. It's not pure science, and this may be why you've got a greater than 50% disagreement rate within the scientific methods panel. And so I would strongly recommend that this panel just be advisory and not a gatekeeper. To reiterate this, I think if you have a strict gatekeeper function of the scientific methods panel, you're going to severely mitigate the importance of NQF because you're not going to get through measures that evolve standards of care. And for example, on the previous discussant, give you an example of, are there really good prospective randomized controlled studies showing that postnatal visits impact quality? You're probably going to be hard to come up with them. Well, then there will be no metric looking at postnatal visits because it's going to flunk validity due to lack of data. And it will die in the scientific methods panel. That's the problem you get into because you're looking at basic standard of care, provisions of basic standard of care that's not being provided. You can't have a double-blind study to validate the data. It's not ethical to construct such.